Hello listeners, welcome to Views on Health. Back with us on the program after a few weeks is Dr. Thushan Gunaratne, Consultant Vascular and Transplant Surgeon, Colombo North Teaching Hospital in Ragama. A warm welcome to our studios, Doctor, and to the program.
Thank you, Fatima. It's a pleasure to be in your company.
Ours too, pleasure too, from our end. And for the information of our listeners, the topic under discussion tonight is deep vein thrombosis. Over to you, Doctor, to introduce the topic.
Thanks, Fatima, again. A few months back, we had a few chat about varicose veins. People are a lot more familiar with the veins in terms of disease related to varicose veins. And I think I spoke that there are two different types of veins based on where they lie in the body. There are ones that lie superficial, and there are also a group of veins that lie deep in the body. The superficial ones are the ones that cause these varicose veins. The deep ones don't usually cause problems, but when they do, they are actually a lot more problematic and can even be life-threatening. So this concept of deep vein thrombosis is mainly related to the lower limbs, where thrombus means clots form. So the problem lies that in some people, for some reasons, in their deep veins, clots form. Because of this, there can be problems related to the leg itself or the limb, as well as it can cause a fatal event, which we can talk about later on. Just to lay things in common perspective, the blood's got a nice balance. It can't be too sticky, but it's got to be sticky enough. If you cut yourself, you can't bleed forever. The body has a mechanism of stopping that blood flow. But at the same time, you don't want the blood to be clotting inside a healthy vessel. This balance is usually well maintained. Sometimes this balance can be disrupted for many reasons. As long as the vessel wall is nice and healthy, as long as the blood flows, and as long as the blood is of the right constituents, this is not a problem. The problem happens when one of those three become a problem. Western statistics sort of comment that about 50% of DVT occurs in related to a hospital admission. It could be admission for anything, it could be a surgery, but 50% of these people may have blood clots forming. If there's any injury to the vessel because of a surgery, sometimes a trauma or a fracture, these vessels can be damaged. Sometimes after injury, we immobilize the patient. It could be a cast, for example. People have a POP, a plaster of Paris cast. Some people are told to bed rest after a bad problem. They are in a surgery, for example, for a long time. And all these can cause damage to the vessels. And this can predispose them to having clots. Another reason is if the blood doesn't flow. This is not very common. As long as we move around, the blood will flow. The blood will not flow if, for example, a long surgery. Sometimes major abdominal surgeries go for hours and hours. It's less of an issue now, but there was an issue with flights and air travel. A long transatlantic flight, for example, takes plenty of hours. There's enough time for blood clots to set in. It's still very common. People traveling in intercity buses, trans-city buses, there have been enough instances when patients come back saying they had clots forming and complications because of that. So immobilization, elderly people who are bedbound after injuries, after traumas, who are staying in bed, these patients are at risk because of the blood not flowing well enough. Some people have issues with their blood constituency. Pregnancy, for example, affects how the blood flows. Blood can be extra sticky, in those instances. If you're taking hormones, which could be for supplement for menopause or hormone replacement or part of your fertility treatment, for example, these can cause blood to become too sticky. A few people have inherent problems in their blood constituency, and these people might find that their family history was there. Maybe a parent, a maternal or paternal relative had an issue with blood clots. Regardless of how the blood clots form, when they do form, it causes a problem. So that is how this DVT problem happens. Mainly a problem of the lower legs, because the calf muscles and the calf veins tend to be a lot more stagnant. But it can also happen inside your body, even the pelvis or even in the internal organs. So when varicose veins were really a cosmetic issue, DVT, I said, is more of a bigger problem. It's not common, but when it happens, it can be even fatal. What it may cause is you need blood to flow into the leg, you need blood to flow out of the leg. If by some chance the bigger veins are blocked, then the blood won't flow. And there's a very rare instance where the blood block might cause the leg to become a gangrene or death. More worrying is some of these tiny clots, they can break off. And if they break off, they are more likely to end up in your lung. Sometimes it's just a shower of tiny clots. And it doesn't cause a lot of problems. But if a bigger enough chunk breaks off, you could die. And that's called pulmonary embolism. So DVT happens because of these reasons. And the worry is that it can cause a problem with the leg. And the even bigger worry is that it can cause death through a fatal event called pulmonary embolism. In terms of data in Sri Lanka, we really don't know. Most of our patients are discharged out of hospitals. We don't always see. Some people suddenly die. We never know what the reasons are, but it's still a common enough problem. How would you know if this problem happens? After a long journey, let's say you go to Jaffna on a bus, a good 7 to 8 hours perhaps, and you forget to take a break in between, or it's a night bus, you sleep along the way, your legs aren't moving. A few days later, you might suddenly find that the legs swelling up. The swelling of the legs is a very common thing. Apart from just the swelling, it can be painful, like a bursting sort of pain. And this is a sudden onset thing, not like a chronic lower leg swelling that you have with old age and with varicose veins. The leg is very tender, the calf is very tense, feels tight. It can be red if you're fair in skin color. It be slightly warm. Some people might misunderstand this for an infection. People would think there might be some cellulitis, for example. But it's a distinct pattern, a clinical picture in the right eyes. It's shiny skin, bulging, tense skin, it's red, it's painful, and the history is very clear sometimes that there's been a travel or some use of hormones or after pregnancy or during pregnancy after surgery. And if this is the case, it's very important that one attends to physician and some medical personnel has a look to see what's going on. When you do see a patient who has these symptoms, often we get referred by physicians because it involves the vessels. A vascular person is usually involved. We have a quick look to see how things are. We examine. There are two key investigations we do. One is a blood test, and this blood test is called a D-dimer. It looks at whether a clot has been formed. It is not very specific, but it gives us some inclination as to what's going on. More often, and almost 100% of the time, we do a duplex scan. And the scan can most often pick up if there's a clot. Sometimes if it's very low down in the leg, only the calf, for example, we might miss it, in which case we always ask a patient to come back in about a week's time to see for a repeat duplex scan. But in most instances, we can find what the problem is and where the clots are. And if there's a clot, then we need to look into treat it. Very occasionally, this can happen in the upper limbs, not really the lower limbs. And that'll be because of a different reason. For some structural abnormality of how the veins lie, maybe there is some blockage or obstruction towards the veins. Then it's a different problem. The way we deal it is different. But if it's a lower leg DVT, and there's a very clear history as to why this happened, the patient is not suffering from a cancer, for example, or it's not terminal or it's not bed-bound, then we look at thinning the blood or taking the clot out. We don't often take the clot out unless it's an essential emergency, and we will decide as vascular surgeons what those instances are. But we almost often give a blood thinning drug, such as warfarin, for example. So that is how this whole presentation happens. That is how we diagnose, and that is how we treat. If there is a near fatal event, like patient suffering from pulmonary embolism, patient is unstable, then of course we need to act swiftly and try to fish the clot out early. But otherwise, it's usually allowing the body to take the clot out themselves. Make sure that we help the body by thinning the blood. We try to look for risk factors that might have provoked this to happen, and if patient is on hormone treatment or has had some vascular anomaly or something we can correct, we'll always advise them to correct it and help them to do so. It's very important that they have some sort of compression. There's a lot of worry amongst people who had DVT that they should stay on a bed. Often doctors themselves say, it's a blood clot, it can break off and go to your heart or lung. Don't move, stay on the bed. That is no longer the case. It's important that the patient becomes active. We do not want clot to form in the other leg while all this is happening. But it's also important that the patient has some compression. And we use what are called compression stockings to make sure the legs kept nice and tight and doesn't allow the swelling to take up too much. Having done all of these, then it's a lot about telling the patient to be careful. We try to find out why this happened. At some point, we often request the opinions from a hematologist. They are the doctors who look into the blood and the blood process. They sometimes do specific tests to look at whether the patient might have had a risk factor that is congenital or idiopathic or inherited in terms of a blood coagulation problem. We look at various structural anomalies at the same time and try to figure out why this might have happened. Most often, these patients will require a good 3 to 6 months of medication. And that's how things are in terms of what this DVT is. It's really important that as people, I think we should be aware that anybody can have it, not necessarily healthy or unhealthy. There isn't always a known risk factor. They might not know what's going on. Suddenly it's an event that triggered it, and you suddenly find your legs or arms swelling, or leg swelling especially, and you get diagnosed with this blood clot problem. And then this whole chain of events of testing and things happen. If a person wishes to know, I am going on a long trip, it's my job or my lifestyle, I need to travel, I need to be on flights or train, how I can protect myself. I think especially in females, it's important that they try and minimize the use of hormones. I say hormones is really the estrogen hormone that causes the blood stickiness. And sometimes the physician or the gynecologist might be able to help in change in the tablets to a non-estrogen hormone replacement. That's something they should discuss. It's also important that we stay healthy. Hydration is very important, especially in Sri Lanka. It's very warm, very humid. You lose a lot of fluids by just doing nothing. And it is easy for the blood to be sticky if you're dehydrated. If you're traveling for long distances, if you're doing something in this heat, daytime, very important you have a bottle of water with you. Keep on drinking, keep yourself hydrated. If you're traveling, if you're a passenger in the car or a vehicle, if you're traveling by bus, it's important you try and move. Let those blood vessels move a bit, get the calf squeezed a bit, pump those muscles a little bit so the blood moves around. Even if you can't get up and walk around, it's important that you can try and at least put pressure on your toes, for example. Put pressure on toes, lift the heel up. Do it the other way, keep the heel and lift the toes up. Get the ankle to move around a little bit so the calf muscles squeeze a bit. Every couple of hours, try and do the stretching. Don't stay the legs crossed, for example. Keep your legs uncrossed. If you can, take a quick short walk. Walk down the aisle of the bus or the plane or the train. Get those muscles moving. There are special types of socks that people can use. These are called Anti-Embolism Stockings, which are available in any pharmacy really. Sometimes they're called flight socks. And you can use these if you're known to have problems and you want to be safer. If you're pregnant, for example, you're traveling, you are at a time of risk during those periods. Important you keep on doing such things to safeguard yourself. So that's about DVT.
Doctor, thank you for that very detailed and lucid introduction to the topic. Would you say that women are more susceptible than men to this condition?
Probably yes. Most often it is patients related to hospital admission that do have DVT. For people who have DVT without a hospital admission or who have no real risk factors that are clinically known at that time, females tend to be a common denominator in relation to pregnancy, in relation to their hormone activities, sometimes obesity, overweight, and populations who are obese, who are overweight, are at risk. A lot of people have worries that they have varicose veins and therefore they are at risk of DVT. That is not really the case. There is no real association or risk factors for varicose veins. If you have had DVT, you may have secondary varicose veins, but that is not due to the varicose veins itself. But you are right. In a certain population, females are more common, but it tends to be more of a problem of people who are either admitted to hospital, have gone through surgery, or especially the elderly people who are not very mobile, who are bed-bound, immobilized, and those who have cancer, such people.
Doctor, when you say that, talk about pregnancy and this condition and hormone treatment is more associated with women, and therefore this condition can set in at a pretty young age. If that is the case, am I right?
Absolutely. There are enough young people who have had DVT. They will usually have a risk because of some problem. Pregnancy, of course, is unavoidable. It's a physiological event. It's not a disease. But with a fetus in the pelvis, that is going to cause compression on those veins, and the blood flow won't be as ready as a normal person. At the same time, there are multitude of hormones that are surging in the body. Your legs are anyway going to swell up. They may have varicose veins. They don't tend to be very mobile. All these will predispose them to having deep vein thrombosis. Is a very common request to give opinion in maternity hospitals for patients who have a new onset swelling of their legs. Young people would also be more likely to have some genetic abnormality in their blood, especially if you're young. There wasn't a very clear history as to why this happened, no real travel history, no real immobilization history. Then if you're young and having those things, we would probably ask a hematologist to give the opinion. These are called thrombophilias or blood sticky disorders. So yeah, those are why we might be more worried in a younger person.
And end of the day, this is treatable.
It is. It is treatable. It is also preventable. It's very important to know that it is preventable. If we do take the right steps, right measures, we can prevent it. If by some chance it happens to you, we can treat it. The degree of how aggressive vascular surgeons are based on a lot of factors. It's probably not the forum to discuss those, but we can be very aggressive if we want to and try to take the clot out immediately. Those aren't without complications, but we would take those risks with the patient if it was an absolute necessity. And these are really more life-threatening or limb-threatening events. Otherwise, it is more for treatment, which is a more gentle, allowing the body to take its course and trying to get those clots out. But we would support the body to not allow the blood clots to keep on progressing. And that is where those medications that are called anticoagulants come into place. There are a group of people, I just say this for passing, that cannot have anticoagulation. There are risk factors for that. And sometimes we use what are called filters to prevent the blood clots from reaching the lung. But the spectrum of how we treat, and we may be aggressive or maybe gentle in our management.
Can it recur?
Absolutely. The problem is once DVT happens, once the clots have set in, by the time they resolve in whatever way it happens, it does damage the lining of the vein. Those valves that are there are damaged, which is why that they have more prone for recurrence of DVT, and also what is called post-thrombotic syndrome, where the legs have become quite swollen up, pigmented, ulcerated, almost like a bad case of varicose vein disease. And therefore, those patients should be extra cautious. Some people who get repeated bouts of these, we would advise them on being on lifelong anticoagulation.
Now, is it the legs that are more affected?
Yes, so 90% of the time it's the legs that are affected. Based on our pattern of lifestyle, the legs are more dependent all the time, more likely for stagnation to happen in the legs than the upper limbs, for example. It can happen in the pelvis if there is some mechanical obstruction, but the calves are the primary focus of how these clots happen. Once they form, they do propagate along the veins. It can be on one leg, on the other leg. Sometimes the entire system's blocked, but the legs are more common.
Because end of the day, if you say that both legs can get affected, or it's evident, it manifests in both legs, that means it is the way it happens. It's meant to happen like that.
Well, not necessarily. We are supposed to be moving around. We are supposed to be mobile. We're supposed to be healthy and active. When it's not the case, and if it's a more general problem that affects this, it will affect both legs equally. But it will usually set in one leg first. What I meant was both legs be affected. At one point, the veins confluent together and they join one common vein. If along one leg it ascends and reaches that common confluence, it effectively blocks the other leg's venous blood from coming in as well. So it's like that both sides can be affected then.
Does the condition make movement difficult?
Yes, it'll be very painful, difficult to move, swollen leg. Some people would have some light fever, a bit of temperature. So you'll probably find a lot of pain, not excessive, but decent enough pain that you'll notice something is wrong. And that is the point that we should discuss and consult a doctor to see.
And at that point, what happens?
So that's where we get involved, and we do a few blood tests I spoke to about, and then a scan. So the blood test, and more specifically the scan, combined with the clinical examination, is the one that helps us to figure out is there a clot or not. And once that is diagnosed, like I said, we start treatment based on how aggressive we want to be. We advise them on how to take care, to be precautious so that it doesn't happen again. We warn them about the risk of pulmonary embolism, which is fatal, and that the risk of pulmonary embolism is effectively for the first few days until the blood is thin enough through the medication.
So you did say that when you're a person is immobile, say like traveling long distance, maybe in an aircraft or on a train, whatever, bus, and it can sort of begin to sort of set in some way where it shows a day or two later that there's a problem because the pain sets in, or maybe swelling, whatever.
Yep.
But taking from there, I mean, would you say once you treat or in the process of treatment, you will advocate movement?
Yes. So there was a notion beforehand that you should not walk or you shouldn't move, stay on a bed and rest if you have DVT. That is not the case. You should move around, provided there is compression on the leg, provided you have started treatment. Once those two are there, you should move around. It's very important you safeguard yourself so it doesn't happen again.
Doctor, your take-home message.
So DVT, I think, is a common problem that we are not very well aware of. It's important to be aware of why this may happen and to be aware of the symptoms when it happens. It's also important that it is completely treatable. It's also important that we know that it's preventable. And if you're at risk based on your lifestyle, based on a surgery, based on your profile, it's important you think about those preventive measures to to make sure that clots don't set in.
Thank you, Doctor. We end this interesting discussion, deep vein thrombosis, on that note. And thank you to Dr. Thushan Gunaratne, Consultant Vascular and Transplant Surgeon, Colombo North Teaching Hospital in Ragama, for being with us on the program and sharing your expert knowledge on this topic. Thank you so much, Doctor.
Thank you, Fatima. It's a pleasure to be here.
My thanks also go to Nishanta Manik Divala for technical assistance. I'm Fatima Razik Kader. Saying good night and hoping to catch you next Monday same time on Views on Health.